management of ischemic stroke and residual risk control. I want to introduce firstly the other two moderators for this morning. The first one is Professor David Wang. David Wang is our old friend, or so many titles. He's currently the professor and director in the United States, the Barrow Neurological Institute, St. Joseph Medical Center. And the other moderator is Professor Liping Liu. Liping Liu is a professor of Beijing Tiantan Hospital, Capital Medical University of China, and is also a famous professor for critical care for neurological disorders. So, first I want to transfer the moderator role to Professor Liping Liu.
All right. Thanks, Professor Xi, and for the introduction. Dear colleagues and friends, welcome to join us for the second session of the Asia Pacific Stroke Islands project, which hosted by the Chinese Stroke Association. And we select the interesting topic and invited the experts from Asia Pacific area for trying to make further communication and call for the collaboration if there are some opportunities. And thank you all for the contribution and the which we have the interesting discussion today. Thank you.
Okay, thanks to Liping Liu. Hello, David.
Hi.
Would you like to say something?
Sure. It is quite an honor to be part of this very nice alliance. I think it's very important because the topics we're about to talk about is very particularly important for stroke prevention, especially in Asian population. And we have learned that this intracranial disease and lipid control and other risk factor management are a little bit different than the other parts of the world. So looking forward to learn from our speakers today and have a very nice discussion on this topic. Thank you. I'm looking forward.
Thank you very much. Now we're going to our topics. Liping.
All right. So, Andy, would you introduce the first speaker, Professor Yingqun?
Yeah, it's your turn.
All right. So let's welcome to the first speaker, Professor Yingqun Wang, also from Beijing Tiantan Hospital, and he's the leading professor in China and Beijing, and doing a lot of clinical research regarding the acute stage and secondary prevention. And he serves as the president of Beijing Tiantan Hospital and also the director of a couple of the first level, national level institute. And he is the chief editor of SVN, which official journal of Chinese Stroke Association. And so let's welcome his talk today is for the secondary prevention for ischemic stroke and residual risk. Please, the meeting organizer. 对，请后台协助我们。
抗炎治疗呢是面对的是去脑血管的二级预防的相关一个研究。大家知道，二级预防目前证据最多的是抗血管药，其次呢是他汀，那么再往后呢是降压和降糖。那么有关抗血管治疗呢，可以说是最近的10-20年间研究最火热的一个领域。那么其他领域呢，从降压是2000年的证据，那么降脂治疗2006年的证据， 降糖治疗呢，那么尽管这个不太长的时间，但实际上这个证据呢强度呢并不是特别高。所以从抗血管来讲呢，我们最近几年的研究主要集中在阿司匹林为基础之上的这种叠加治疗。大家知道阿司匹林的最早的研究，临床研究是1997年，那么实际上获得宣传学证据呢是在1997年。那么这是发表在《Lancet》的杂志上2个3期临床实验 CAS-IST。从 CAS-IST 这个出现之后呢，从97年，阿司匹林成了我们这个脑血管病、缺血脑血管病早期的金标准治疗。但是尽管用了金标准治疗，但是复发率仍然还是超过10%。之后呢，人们一直在想探索联合抗血管。联合抗血管的代表研究呢是中国的畅思治疗。畅思治疗大家知道是2013年发表，它是在中国114家医院选择5170个病人，那么分成短程就3周的联合抗血阿司匹林加氯吡格雷和阿司匹林做这样头对头的对照。结局呢是发现，那么联合抗血管这一组它的复发率从11.7%降到8.2%，它的相对风险相差32%。同时呢，并不增加任何程度的出血性卒中和重度出血，也就是病人整体是安全的。那么从2013年可以说是我们抗血管的一个分水岭。那么在之前呢，指南都是推荐的联合单一抗血管。从2013年之后，一系列这个联合抗血管的实验，把我们脑血管病的临床推向了联合抗血管时期。从联合抗血管之后呢，我们这个中心的同事呢一直在寻找在联合抗血管基础之上能不能再进一步增加疗效，也就是想到了用精准预血的方式。那么首先研究的呢是氯吡格雷体内代谢的相关基因，大家知道相关的基因位点是28个位点，结果发现影响畅思疗效的主要是4个位点，一个是 ABCB1， 一个是 CYP2C19， 还有 CYP2B6 和 F2R。那么其中 CYP2C19 呢是2016年发表在《JAMA》杂志上，它证实中国人CYP2C19 功能缺失人群是 58.8%， 同时发现这个基因阻代性对疗效具有重要的影响。之后呢2017年，这个我的同事呢发现了 CYP2C19 的功能这个缺失的携带数量和结局之间有量效关系，这也是发表在2017年 Circulation 杂志上。 Circulation 呢也给了非常好的评价，当时请了这个基因的发现者 C 蒙教授，他说这项研究标志着基于 CYP2C19 基因指导的临床实验的时机已经到来。之后呢，我们国家中心呢开始探索做的临床的这种基因指导的这种治疗。2017年设计了2期临床实验 PRINCE， 这个大家熟悉的王子研究。PRINCE 研究呢是发表在2019年 BMJ 杂志上。那么一共入选的病人500多个病人，他用的终点是一个血管活化的终点。结果发现，当同样基因背景下使用绕行 CYP2C19 的替格瑞洛比氯吡格雷它的血管功能抑制多增加60%，同时呢临床疗效也有好的趋势。那这个研究发表之后，就需要呼唤着有一个3期临床去来证实基因指导的这种临床实践方式是不是可行。之后呢，在13-5末期，我们设计了它的3期临床实验畅思2。畅思2呢是在中国202家医院，那么一共顺序纳入了符合畅思标准的病人，一共是11255人，用了我们床旁的基因检测，那么发现功能缺失人群6412人，这样呢分为氯吡格雷组和替格瑞洛组，这样在3个月之后发现，那么在功能缺失的时候用替格瑞洛去取代氯吡格雷的话，那么它的复发的风险可以多降低23%， P 值是0.008，是统计意义的。同时呢，也不增加任何程度中度出血。所以从97年的 IIT CAST， 那复发率从17降到11。到2013年的畅思，那么如果都实施的话，我们复发率可以从11降到8%。如果用精准的方式的话，畅思2的方式的话，复发率仍然还可以继续下降到6%。但是再往下下降，似乎抗血管药是已经不再起作用。所以这个时候呢，我们把这个6%的复发风险称为叫残余风险。 残余风险都是什么原因呢？这个，那么前年呢，在ISBN 杂志上发表了我写的一个关于残余风险概念的一篇文章。这篇文章呢，把残余风险分为3类。那么第一类残余风险呢，我们叫质量残余风险，就是我知道怎么做，我不去做，就是蓝颜色的。绿颜色呢，我知道道理，但是没有证据，这叫证据残余风险。黄颜色呢，就是我们不知道道理，也不知道怎么做，这叫未知残余风险。未知残余风险未来是靠多组学技术去解决。那么在绿颜色这一部分，到底有多少我们知道道理，但是没有临床证据的这些东西是多少呢？那么去年年初，那我的同事潘岳松，那么在Journal of Stroke 发表了这种已知残余风险没有证据的到底是哪些东西。这个呢是发表在韩国这本杂志上，结果发现有4个因素决定了我们目前可能干预或者说不能干预的这个因素，其中前2个因素无法干预，其中可干预的因素是2个，一个是白介素6水平超过 5.63 纳克，那么第2个呢合并中动脉狭窄。那这2个的风险呢分别增加 65%， 一个是增加 57%， 也就意味着无论是我们干预中动脉狭窄还是干预炎症白介6的话，复发率还可以进一步下降。那么在同时呢，我们同事在最近几年一直在做这种各种炎症因子和复发之间的关系。这个研究呢是2016年、2015年先后发表的几篇研究，主要用的是当时2013年畅子研究的血液。那么先后发现炎症因子的 CD40L 还有超敏 C 反蛋白和 LPPRA2 都和结局之间存在着这种关系，也就是这种炎症因子增加的话都会增加复发。其中 C 反蛋白每增加1个毫克，大概复发率可以多增加 26%。之后呢，利用 CSR3， 我们再次发现，那么血中的 CRP 的浓度和复发之间有个量小关系，而且非常有意思的发现，只要这个 CRP 增加越早，在24小时之内，它的预测复发风险会更高。那么超过72小时，这个预测复发风险就很低了。也就是在早期早一些把 CRP 降低，有可能是我们降低复发非常重要一个手段。那么之后呢，再利用3在2022年，那么就今年发表了一个研究，证实了白介素6也跟复发之间呈现一个量小关系。当白介素增加的时候，大概复发会增加 34%。那么用3呢，在去年的 Stroke 杂志上发表了其中的关于6种炎症因子对结局的影响。这个可以发现，炎症残余风险可以增加了中国卒中病人复发风险 37%。那这个因素呢，是和 CRP 的浓度之间有量小关系。这篇研究在 Stroke 发表之后 ，Stroke 也给了2页的述评。述评认为，那么3的研究是一个采用标准化的大型前瞻性这种研究，增加了有价值的新证据。那这个数据支持炎症作为中风未来血管事件的这种风险因素，表明这种因素呢跟胆固醇之间有一个协同关系。那么这个研究进一步支持抗炎治疗用于卒中2级预防的随机临床实验的基本原理。所以在此基础之上，我们一直在寻找一种能够降低复发的这种新的抗炎治疗手段。那么最近呢，国家中心就此校这个团队又有一个新的发现，这是用 CSCA 100多人的数据再次证实早期的 CRP 的增加可以与90天的功能预后不良和复发之间有关联。所以这个再次提示我们，抗炎治疗现在不得不放在我们当下的工作的重点。所以抗炎治疗到底用哪个靶点呢？这是引起前面我们研究的这些靶点，从最早的炎性小体 NLRP3， 那么再有之后呢，白介一贝塔，那么白介一贝塔受体，还有白介素18、白介素6，到最后的 CRP。那么这是我们目前引起复发的主要的炎症通路，也就意味着我们找到一种药物，只要阻断某一个这个关键靶点的话，都可以使复发下降。实际上这些靶点在心血管都做过很多尝试，其中炎性小体做过2个3期临床实验，拉杜口2和考当时用的是秋水仙碱。那白介素1的这个靶点呢， 就用的 Cantos 研究来知道这是用了一个单抗。那么白介六这个呢是现在只做过2期临床，所以证据在心血管证据最多的仍然是 NLRP3 炎性小体，也就是秋水仙碱。那么秋水仙碱在心血管的2个重要研究，大家简单回顾一下。一个研究呢叫 COCO 的是想用秋水仙碱来在急性心梗病人，他所谓急性就是发病30天的急性心梗病人，每天接受低剂量的秋水仙碱，就每天0.5毫克，看一看他的联合血管实验是不是能抑制。这个研究呢，一共纳入病人是4745人，最终的结局发现，每天使用低剂量秋水仙碱可以使联合血管实验下降23%，P 值0.002，这是个阳性结果。我们看它的次要重点里边，对各个次要重点降低最明显的是卒中下降74%，这要比心梗本身只下降9%要高了很多。这个研究再进一步提示，抑制了这个 NLRP3 的话，卒中的这种预防作用是很明显的。这个研究呢，这是它次要重点的具体一些数据。这是卒中，尽管统计学这个大家看到了 0.26， 它的那个90%的可信线的上限也就 0.7， 也就是统计学本身是小于 0.05 是有意义的。这个研究呢是发表在《心肝血杂志》上。之后呢，这个在欧洲心脏杂志上发表了它的其中一个重要的亚组，这也是我们下一个临床实验依据的一个研究。就是尽管它用了30天的这种时间窗，但是发现时间和启动治疗时间是高度相关的，就治疗越早，它把治疗分为3天、4到7天和7天以上，发现越早效果越好。那这个研究在这个欧洲心脏杂志2020年发表之后，那么写了一个非常重要的述评，这个述评就是说越早越好，这是我们也是下一个临床实验要依据的。之后呢，这个在 circulation 的这个分册上发表了有关秋水仙碱的药物基因现在没有发现和疗效相关的药物基因，只发现了2个位点和它的胃肠不良反应相关。那这个基因呢，似乎我们用不着这么早在用基因指导的这种临床治疗。第二个大型3期实验是2020年在心肝血杂志发表的 LADUCO-2， 那么这个呢是用的是稳定期的心梗病人，就是他发病在30天之后的这种心梗病人。这个研究呢一共纳入是5522个人，那一半病人同样使用低剂量秋水仙碱，另外使用安慰剂。他看到它的主要终点和这种次要关键次要终点都有统计意义的这个下降。亚组分析呢，同时也发现卒中下降了34%，也是一个在所有次要终点中下降最明显的一个部分。这2个研究给了我们一个信心，就是抑制 NLRP3 的话，确实有希望使卒中的2级预防再次能够降低。那么这之后呢，做的一个分析，这是单纯对于卒中的这一部分，对于卒中这几个研究放在一起的话，大概整体的实践可以下降46%。这是我们设计下一个临床实验那个最主要的一些数据依据。那46%在所有的一些东西放在一起的话，大概对不同时间下降，卒中下降是最明显的。那么既然在这个炎症的这个轴线上，心血管的实验已经很充分了，脑血管没有道理它不是有效的。所以但是实际上在临床中目前还没有脑血管的实验。这是大家知道 Cochrane Library 那么做的一个联合分析，最后用这个抗炎和卒中作为关键词去检索的话，最后纳入的是0，也就是没有一个研究在卒中的3期临床实验中用了抗炎治疗。但实际上国际上现在有2个抗炎治疗在进行中，一个呢是都柏林大学做的 CONVINCE 研究，这 CONVINCE 研究呢是科瑞教授牵头，它是一个国际多中心，17个国家，纳入病人数是3154例。那么我现在怎么算，现在这个样本量不够。那么他预计呢是每天秋水仙碱用3年的时间，就看一下联合血管实践。这个研究呢在2021年完成招募，2023年就2年再完成随访明年。但实际上我知道这个研究目前还是 没有按计划能够完成。第二个研究呢是澳大利亚悉尼大学现在设计的研究，叫 CRISPR 研究现在还没有开始，这是预计呢会在澳大利亚和新西兰纳入1500个这个去性卒中病人，也是用每天0.5毫克丘式鲜碱看一下联合时间的下降。那这个实验也不是一个经典的3期，所以这2个研究都不是改变指南的研究。所以国际上现在急需一个改变指南的秋水仙碱卒中2聚方的研究。所以在这个基础之上呢，国家中心今年计划在8月份启动CHANCE3，就是CHANCE 3期研究。CHANCE 3期研究选用的所有的病人都是CHANCE人群，只增加了一个标准，就是 CRP 超过2毫克，就是 CRP 增高的人群，就是意味着炎症反应比较明显的。大概在CHANCE人群中 ，CRP 超过2毫克的占了总人群的43%左右。这样我们把CHANCE人群的43%拿出来之后呢，一组病人每天使用0.5毫克丘式鲜碱。那么用的方式呢是前3天用 loading dose， 就每天用1毫克，之后第4天改成0.5，这样用3个月的时间，对照组用安慰剂。那这个研究预计纳入的病人，按照目前样本量估算是8238人。那这个整个设计现在已经完成。那么在用的病人呢，也是在早期，就是24小时，跟CHANCE是同样的时间窗。结局呢跟前面2个结局都不一样，我们仍然用了CHANCE结局，就是 any stroke 任何卒中。这个研究呢是由我们中国的这个昆明制药提供了全部的秋水鲜碱。那么现在这个学术委员会参与方案设计的我克雷张斯坦、施普东教授，那么伊森教授还汉克教授，现在第一版的方案现在已经基本完成。那么预计下一周呢 ，Pre-CHANCE3 的第2个临床实验将下一周完成。我们在之前做了2个预实验，一个预实验就是秋水鲜碱的剂量，第2个预实验就是床旁快速的 CRP 的测定和标准实验室测定之间的关系。都会在下一周都会完成。这样我们从CHANCE的联合抗血小板到CHANCE2的精准抗血小板，那预计在明年年底，我们希望CHANCE3能够结束。结束之后呢，再为我们去性脑血管病2聚预防再增加一个新的中国的证据。所以去性2聚预防呢，尽管我们有了很多研究，但实际上这些研究还没有完全解决残余复发风险。我们今天讨论的是抗炎，实际上后面还有很多靶点。今年下半年，我们中国将会和美国、那么西班牙在共同发起一个11因子抑制剂做2聚预防的这样一个3期临床试验。那么预计是16000人，现在也在方案的最后设计中，预计7月份完成方案设计。明年上半年中国的入组会开始。所以我们这样的一个新的实验，能够进一步降低卒中的复发率，能够为卒中2聚预防提供更多的循证学证据。那再次感谢大会给我提供的时间，也感谢过去所有参与国家中心的研究者、资助者和患者，谢谢大家。
All right. We would appreciate Professor Yungjun Wang's presentation and providing some new idea and design for the next RCT regarding the secondary prevention and the rescue risk control. And so let's welcome next speaker today from Professor Thomas Leung and from Chinese University of Hong Kong. And Thomas is well-known and the famous experts regarding the stroke management and imaging, and also the intracranial artery stenosis. And he has a lot of clinical research and the certificate from national and international institutes. And he also focus on the interventional and the endovascular treatment. So today we would welcome Thomas to present the topic regarding the management of ICAS and risk factor control. Please, Thomas.
Thank you very much for the very kind introduction, Professor Liu. Let me share the screen first. all see the screen?
Yes.
Okay, thank you very much. Good morning, friends and colleagues. It is really my great pleasure to join this Stroke Alliance, and my pleasure to share with you in the coming 20 minutes the management of ICAT and the risk factor control. So usually in presentations of ICAT, the presenters will usually give 1 or 2 slides showing the importance of ICAT and the impact of ICAT globally or locally. But seemingly we have a different observation in the last 15 years in Hong Kong. I don't know whether you will share with me the same experience in your own hospital or not, because in this recent study, we examined the evolution of ischemic stroke subtypes in our hospital. So it's a hospital-based observation study in the last 15 years. If we differentiate all those patients according to TOAST classification, cardioembolism, large artery disease, small vessel disease, etc., you can see in the here is a large artery disease from 2004 along in the following 15 years up to 2018. Actually, the proportion of patients having large artery disease, it was gradually decreasing, while the patient with cardioembolism is gradually catching up and be more important. And during the same period, most of the risk factors were actually comparable, except the smoker were actually decreasing at the same time. You can even be more surprised if you see this slide. In the top is the 2-year recurrence of different stroke subtypes. You can see here for the ICAT in 2004, the 2-year recurrence can be up to nearly 20%. Okay, so in 2016, you can see the recurrence of ICAT, intracranial arteriosclerotic disease, was actually only 5%. And at the same time, in parallel, the patient receiving dual antiplatelet therapy for ICAT increased from 1.5% up to 32% in the end of the study period. And the statin prescription for ICAT patients was from 56% up to more than 80% in 2016. And therefore, with this trend, we suspect that the ICAT was actually of decreasing prevalence in incidence in Hong Kong, and could be due to improved risk factor control. We don't know whether the previous postulation of genetic predisposition was actually can be modified by very stringent risk factor control nowadays. And when we talk about the medical management or endovascular management of ICAT, one must not forget to appreciate the pathoanatomy and also pathophysiology. Here in the histological section of the middle cerebral artery, you can appreciate the arteriosclerotic plaque with a very thin fibrous cap with intraplaque hemorrhage and lipid deposition. And the intracranial artery is a very thin medial layer, and adventitia is also very thin, and therefore it's very fragile. And more importantly, you can see the perforators coming out, often even within these stenotic segments. And therefore, if you cannot appreciate this pathoanatomy, for example, in Sampras, you can appreciate there will be a higher incidence of perforated stroke as a complication when you have balloon angioplasty or stenting, and these arteriosclerotic plaque may smear over the opening of these perforators, leading to perforated stroke complication. And of course, with the fragile arteries are also more prone to rupture or avulsion during the endovascular procedure compared to very thick extracranial arteries in the proximal carotid arteries. The pathophysiology is also very important. The 3 most common stroke mechanisms here are listed here is the artery-to-artery thromboembolism, as well as the hemodynamic failure and hypoperfusion. And the periartery occluding penetrating arteries, like here on the left-hand side in this angiogram, you can see the very stenotic basilar artery, and there will be stenosis because of the plaque involving the adjacent branches, and leading to this periartery occluding penetrating arteries or adjacent branches. And this is the stroke mechanism least studied. And in the management of ICAT in the last 20 years, most of the investigators will focus on preventing the artery-to-artery thromboembolism, as well as improving the distal hypoperfusion. And our group has correlated the stroke mechanism with the clinical relapse in the first 12 months from incident stroke. You can here appreciate the combined stroke mechanism, or the mixed stroke mechanism of artery-to-artery thromboembolism plus hypoperfusion has definitely higher risk of recurrence compared to other mechanisms and in the recurrence. And therefore, the appreciation of the stroke mechanism as a diagnosis will be very important, particularly individualized treatment is needed. And therefore, in the last 2 decades, we can see the evolution of treatment will center around whether we can reduce the recurrent thromboembolism or improve hypoperfusion. And there are 2 general approaches. One is the aggressive medical management with dual antiplatelet therapy, or DAPT or DAPT, plus very intensive control of vascular risk factors. Or N, medical therapy plus endovascular procedures. And in this talk, I will only summarize those randomized clinical trials or the pre-specified subgroup analysis in symptomatic ICAT patients. And those with asymptomatic intracranial stenosis are least investigated. So in contrast to the last talk by Professor Wan, I will focus on ICAT patients in contrast to those overall ischemic stroke prevention strategies. So how to prevent recurrent thromboembolism? By warfarin, low molecular heparin, or antiplatelet therapy. So this is a typical patient with an M1 stenosis here. You can appreciate at the onset of the incident stroke, you can see a high-grade stenosis and with an embolic infarct in 3B. And within 3 weeks, he developed a recurrence. You can appreciate by the same projection in the same modality of 3D-RA, the distal part of the plaque was missing and dislodged, probably to cause another embolic infarct. So how are we going to prevent this? In more than 20 years ago, we thought about warfarin. So in this WARSIT study, they randomized 569 patients with a mean follow-up of 1.8 years. Nevertheless, the adverse effect, that is in terms of mortality, the major hemorrhage, or myocardial infarction or sudden death, the patients in the warfarin group perform far worse than the aspirin group. And therefore, in this study, they concluded that aspirin is better than warfarin. So how about low molecular weight heparin? In this study, with Professor K.S. Wong as the principal investigator, it's a multi-center studies in this study in Prince of Wales Hospital. And although it's a negative study, and we found that low molecular heparin in terms of fluoxetine is not superior than aspirin in prevention in terms of a primary outcome of a better outcome in 6 months by the Patel index. But we found that in the subgroup analysis of this FISTRIS study, the low molecular heparin actually improved the outcome among older patients, and in aspirin-naive patients on admission, or in symptomatic posterior circulation arterial disease. And there in some subgroup of patients, they may benefit from the low molecular heparin. And the interest switched to antiplatelet therapy. And TOS1 in the study on cilostazol, and which was an angiographic study in Asian population. It's a small-scale study. The study randomized 135 patients with symptomatic stenosis in the middle cerebral artery or basilar artery. They either randomized in the cilostazol plus aspirin or aspirin alone group. The endpoint was a progression of ICAT lesion on MRA, but not a clinical endpoint. They found that actually the cilostazol and aspirin group have a significant reduced progression in terms of the MCA stenosis in the MRA, and therefore they proceed to a TOS2 study. The TOS2 study is again an angiographic dual antiplatelet therapy study. They randomized 457 ICAT patients with also stenosis in MC or BA, but into 2 groups. Both are dual antiplatelet groups, cilostazol plus aspirin or clopidogrel plus aspirin, and they performed MRA and MRI in 7 months. The primary endpoint was progression of ICAT in comparison with baseline MRA. However, they found that cilostazol and aspirin did not reduce progression of ICAT lesions. And also in terms of the cardiovascular events or new ischemic lesions in MRI or major hemorrhagic complications, both groups actually performed similarly. And therefore they conclude that the cilostazol plus aspirin was not better for stroke prevention than clopidogrel plus aspirin. So Catharsis is a Japanese study also focused on cilostazol. It's a smaller study. They randomized 165 patients with more than 50% stenosis diagnosed by MRA. And they randomized into cilostazol plus aspirin or aspirin group. And they found that it's also a negative study. In terms of progression, there's no significant difference between both groups, and the major hemorrhage was similar in also both groups. However, they found that the cilostazol and plus aspirin prevented a combined secondary endpoint of all vascular events and new silent brain infarcts when compared to aspirin alone. So the interpretation of cilostazol-based dual antiplatelet therapy is quite limited because of the small scale studies, and those study population were primarily Asians or East Asians. And importantly, the aspirin group, either it's adjunctive aspirin or aspirin alone group, the dose of aspirin was almost always a low dose aspirin, usually less than 150 milligram per day. And that limited the generalizability of the study to other ethnicity. So we provide the recommendation for American Academy of Neurology, and they recommend that the addition of cilostazol 200 milligram per day to aspirin for up to 90 days to further reduce stroke risk in patients with ICAT and low risk of hemorrhagic complication only in Asian patients. And now we talk about the clopidogrel-based treatment. And this is a study also with Professor Keswong as the principal investigator, and we randomized 100 patients of ICAT with large artery disease. The randomized either into a dual antiplatelets with the clopidogrel 300 milligram loading at day 1, followed by 75 milligram daily up to day 7, or an aspirin alone arm, which can be 80 milligram or 160 milligram per day. And we have the surrogate marker as the microembolic signal, and on day 2 and also day 7, comparing to the number of microembolic signal and on screening. And we found that actually on day 2 or day 7, the microembolic signal was significantly reduced by the dual antiplatelet therapy compared to the monotherapy of aspirin. And with this formed the basis showing that the usefulness of the dual antiplatelet therapy, clopidogrel with aspirin, probably in reducing the thromboembolic events. So actually the aspirin clopidogrel combination is the most accepted dual antiplatelet therapy nowadays for the treatment of ICAT. But actually they were supported by only indirect or related evidence. As I mentioned in Claire study, the combination significantly decreased microembolic signal in the stenotic artery. And also in the CARES study, which recruited for the carotid artery stenosis, proximal carotid artery stenosis, they also found a significant reduction in recurrent stroke compared with patients treated with aspirin monotherapy. And thirdly, in the ICAT patients in CHANT study, who are randomized to clopidogrel and aspirin, had a numerically lower rate of stroke at 90 days compared to those with aspirin alone. Further studies of evidence of this combination from the SAMPRESS study. Actually, they combined the SAMPRESS study with the WARSIS studies. And the WARSIS study, who met SAMPRESS entry criteria, was adjusted for confounding factors. And they still show almost double the risk of stroke in the WARSIS study when they were on aspirin alone. And in the SAMPRESS study, a 90-day of clopidogrel plus aspirin had a lower primary endpoint of only 5.8%. So, but the optimum duration of combined clopidogrel and aspirin in ICAT has not been tested in randomized clinical trial, and it remain unknown. And the high rate of stroke beyond the first few months on aspirin alone in Sampras medical arm may suggest further studies needed to determine whether an extended period of clopidogrel used beyond 3 months is actually warranted. So now in the recommendation, the addition of clopidogrel 75 mg to aspirin for up to 90 days to further reduce stroke risk in patients with severe ICAT disease. And of course, they should have lower risk of hemorrhagic transformation of ischemic stroke. So how about patients? ICAT patients could also require anticoagulation, for example, like atrial fibrillation. Actually, the safety of efficacy of NOAC for stroke prevention in ICAT was not established. And the safety of efficacy of adding aspirin to anticoagulation in ICAT patient could require anticoagulation of further condition is really uncertain. But in the WARSIT study, we know that warfarin was actually quite equally effective as aspirin for stroke prevention. And therefore, we're very cautious about adding aspirin to warfarin. And therefore, in clinical practice, we usually will not add on aspirin. So how about other risk factors, for example, like hypertension, hyperlipidemia, and in diabetes? We knew that actually ICAT lesions are very dynamic. In this study, we prospectively recruited 50 patients, and we did an angiogram at baseline and 1 year. We show that actually about 40% of these patients with very high-grade stenosis at baseline, here on the left, actually have significant regression of the ICAT stenosis at 1 year. And it's probably related to the very stringent risk factor control, particularly in terms of the lipid. Here, the low density lipoprotein level, less than 70 milligram per deciliter or 1.8 millimole per liter in our unit among patients with stroke and atherosclerotic disease was found to have reduced major cardiovascular events when compared with a less stringent LDL control. And the post-hoc analysis with in Wall Street and in WARSIT study and also Sampras study also show a lower rate of vascular events with lower LDL. And nevertheless, other lipid-lowering agents like PCSK9 inhibitors or omega-3 has not been specifically studied in ICAT, and further studies may be warranted. And therefore, in the latest recommendation, LDL of less than 1.8 millimole per liter in patients with symptomatic ICAT was recommended. So how about antihypertensives and BP targets? In WARSIT, Sampras, and also CICA's study, which is a Chinese intracranial atherosclerotic study, and patients less than 140 millimeter mercury as its systolic blood pressure was associated with a lower risk of stroke and vascular events. And nevertheless, in the American Heart Association guideline, should the blood pressure, systolic blood pressure should lower than 130 millimeter mercury. But in the WARSIT and also Sampras study, and they compare two groups, and the one group of more intensive control with a systolic blood pressure of less than 120 millimeter mercury, and with a less intensive group of only less than 140 millimeter mercury. They found that a more intensive group, which has a mean systolic blood pressure of 124, had a higher risk of new ischemic lesions on imaging and a larger stroke volume than the standard group. And therefore, in some subgroup of patients with ICAT, may be at risk of having a deterioration, maybe more recurrent stroke or larger infarct size, and particularly in those with hemodynamic impairment and with those with a large reduction of blood pressure from baseline. So the recommendation now is only less than 140 millimeter mercury systolic blood pressure as our guideline. So these are the modifiable risk factors that may increase the risk of ICAT recurrence. But the least investigated is the glycemic control. And because in our own study, we found that those with a higher hemoglobin A1C at baseline and with further reduction of this glycemic control may actually reduce further and enhance the regression of ICAT lesion. But in this, we do not have specific specific studies dedicated to investigate the possibility of reducing the benefit of glycemic control in the ICAT patients in prevention. Professor Cindy Lan has clearly shown that the local hemodynamics in terms of the translational pressure ratio or the wall shear stress ratio in the immediate vicinity of the stenosis may actually related to recurrence. And therefore efforts has been given to either increase the distal perfusion or actually modify the plaque morphology that can be related to the stroke recurrence. And in this study, we found that actually some morphological parameters may actually be related to the plaque progression or clinical recurrence. And therefore, further endovascular treatment by angioplasty or stenting or surgical treatment by ECIC bypass may improve the distal perfusion or modify to decrease the recurrent risk. But a long time ago, we have the ECIC bypass study. We actually, this procedure very likely to increase the risk of recurrent stroke or death. So it's currently out of favor. So how about endovascular treatment? We know very well that in the sample study, they had a very high risk of a complication rate in the stent arm. The 30 rate of stroke or death in the PTAS group was almost 15%, which is significantly higher than in the previous registry studies. And the 1 year rate of recurrent stroke was 20% in the stent arm and about 12% in medical management group. And therefore, they concluded the medical treatment was much better than the angioplasty and stenting. In another study, they used not a self-expandable stent, but a balloon-mounted stent. They found that they randomized 112 patients, which was prematurely terminated because of the safety concern. Because the 30-day primary safety endpoint occurred in 24% of patients, which is even worse than the Sampras group, compared to the medical group of only 9.4%. And in the stent group, with this balloon-mounted stent, the risk was also elevated with 8.6% with hemorrhagic complication within 30 days. And therefore, this endovascular technique was not recommended for ICAT patients. And the conclusion is that clinicians should not recommend angioplasty or stenting as the initial treatment for stroke prevention in patients with severe ICAT lesions. And nowadays, the US FDA only approved endovascular stenting or with wingspan device for patients with 2 or more stroke despite aggressive medical management. And they also should have very high-grade stenosis and also good recovery from previous stroke. But it seems that we have some news from the latest with the upcoming result from the China randomized study for angioplasty and stenting for ICAT patients and the CASSIS study. And they randomized also very high-grade stenosis and stented within 3 weeks from the ischemic symptom onset. And they performed in high-volume centers with a proven track record, and particularly compared with the less experienced operators during in the Sampras era. The primary endpoint was stroke and death within 30 days after enrollment, and they have followed up the patient for 12 months and see the recurrence. And I've heard that the study has been completed, and probably the result will be released very soon. So, ladies and gentlemen, in a future study, we really have to identify the patients truly at risk. The vulnerability, not just in terms of stenosis, but also we need to recruit patients with very vulnerable plaque composition and morphology, and those with very vulnerable global and local hemodynamic factors. And the role of ticagrelor-based dual antiplatelet treatment remain uncertain, although ticagrelor may be associated with a higher hemorrhagic complication. But in those patients with high recurrence, despite dual antiplatelet therapy, may benefit from ticagrelor. And we are not certain also about the role of the low-dose factor 10A inhibitors plus aspirin, or even in the factor 11A inhibitors, which the Janssen will probably have a global randomized trial on this. And the role of the PCSK9 inhibitor and the remote limb ischemic preconditioning remain uncertain, and probably a larger scale of study is warranted. And the impact of CYP2C19 loss of function allele carrier status on clinical outcomes also important in the dual antiplayer therapy involving clopidogrel. So in conclusion, ladies and gentlemen, ICAT is not merely a stenosis. Understanding the stroke mechanism, identifying the lesion at risk of relapse is important. So currently, the dual antiplayer therapy in conjunction with stringent risk factor control, lifestyle modification is the mainstay of first-line treatment. So systolic blood pressure less than 140 mmHg, an LDL level of less than 70 mg per deciliter, and probably a better glycemic control, quit smoking, and the regular exercise at least 3 times per week of moderate intensity may be beneficial. So angioplasty or stenting should only be considered in selected patients refractory to medical therapy after careful evaluation of pathoanatomy. So thank you very much.
All right. Thank you very much, Thomas, for the wonderful talk and providing the much more detailed information regarding the ICAS and either the medical therapy and the interventional treatment. And let's move forward to the panel discussion. And let me introduce the group of the discussion from the different area. And first of all, today we really appreciate the group of colleagues joining us for the discussion. And first is Professor Wong-Gun Ji from Korea. He is a professor of the Department of Neurology and Stroke Center and Simpson Medical Center, and he also doing from the Department of Digital Health and the Science and Technology, which is really important to medical issues, and he also serves as the couple of the national and international association and institute. And the next member is Professor Feng Kun Chi, and from Queen Elizabeth Hospital of Hong Kong. And Dr. Feng is consultant neurologist and the deputy chief of Department of Medical Medicine in Queen Elizabeth Hospital in Hong Kong. And he has been trained in Harvard Medical University and supervised by Professor Louis Kaplan. And also we realize he is the key person in the Hong Kong Neurological Society and the Hong Kong Stroke Society, and also the Secretary General of Asia Pacific Stroke Organizations. So welcome, Dr. Feng. And the next panel, Professor Zhefeng Tan from First Affiliate Hospital of Jinan University. He is a colleague of Professor Anding Xuyan, the serves as the key member of either the China National or Guangdong Province Association and the Institute. And the next is the panel is Professor Xinyi Leng from Chinese University of Hong Kong, and she is associate professor from Department of Medicine and Therapeutics and Chinese University of Hong Kong, and she doing lots of research, either the imaging and the hemodynamic of ICAS. Welcome, Xinyi. Next panel is Professor Jie Li. She's my colleagues from Beijing Tiantang Hospital, and she serves as associate professor of Department of Neurology and focus on the biomarker and inflammation of acute ischemic stroke. And he has been trained in US for a couple of years, and they had a very traumatic publication in the different journals. And welcome. And Professor Bo Hu from Union Hospital and Chongji Medical University in Wuhan, and Huazhong University of Science and Technology in Wuhan, and she is a professor and focus on the stroke and the other neurological disorders. She also serves as the key priority of the results of funding from either the national and the different levels. And she also doing a lot of basic and preclinical research. Welcome, Professor Hu. And so let's come to the discussion today. We list a couple of the potential topic, but not only focus on this. And we are going to talk a little bit like a target lipid management and strategy of anticoagulation or something anti-thrombosis. And either the medical or the interventional treatment of ICAS, and also the long-term of the residual risk, something which were mentioned by Professor Yongjun Wang and Thomas in their talk. So I would like to invite David Wang to moderate the discussion next. David?
Yes, Liping, thank you very much. This has been, can you hear me okay?
Yeah, sure.
Okay. This has been a very educational session from two powerful speakers. And from Professor Yongjun Wang, we have learned that not only he gave us the history of how secondary stroke prevention in terms of addressing the risk factors evolved from the risk factor management to antiplatelet treatment to the newest inflammatory factor control or in controlling inflammation. So that is a new area of interest that may be important to the topic that we're trying to address today, which is the intracranial atherosclerotic disease, or ICAD or ICAS. Then Dr. Long given us I would say the best summary talk of what is going on with the current practice treating or preventing ICAD or ICAS problem, from risk factor management to overall up-to-date summary on how to use, what evidence supported the use of antithrombotics. And what's interesting is that at the end of his talk, his summary is that indeed the current proven treatment seems to be controlling risk factors using dual antiplatelet drugs, reducing smoking, and control glucose. So after all this amount of work by the entire world, we seem to be having still not enough evidence to go further than that. So this is where I feel it's very interesting. And since we have Dr. Su from South Korea and Dr. Chen from also Hong Kong, and so and all the other professors, experts from China, really this topic of should we really endovascularly intervene patients with intracranial disease, I think it's still very much debatable. So if we all believe Dr. Long's presentation, then the AEN's recommendation is no, we should not do that. Or is there a subgroup of patients that you would like to use endovascular treatment to treat? So should we really, in any subgroups of patients who you have really controlled their risk factors well, you feel strongly they should be either have an angioplasty treatment or stenting on top of angioplasty in those patients with ICAD in your practice? For that question, I'm going to ask Dr. Su to see, what do you think? Would you like to do that? Would you say, no, I'm not going to do this?
Hello, I'm Guzhou from Samsung Medical Center. Most of all, I'm very happy to see the Chinese strong neurologist again after the COVID-19 situation. and I'm very thank you for invitation of me. And also I congratulate the great success of SBN recently. I was surprised for the higher impact factors you got from this year, and many Korean neurologists are very congratulate for the great success. Regarding today's issues, I wanna comment two points. The first point is the management of this epidemic in patients with intracranial arterial stenosis. Recently, I published a meta-analysis about the management of this epidemic in stroke patients. In this meta-analysis, we found that the lower is the better for the prevention of secondary stroke prevention. Especially, we focused on the achieved LDL cholesterol after the treatment, and found that the lower until below the 1 millimole per liter, which means that about 38 milligram per deciliter, can also reduce the further decrease of the risk of recurrent ischemic stroke. But this meta-analysis was based on the every type of stroke patient. So I think the patient with intracranial atherosclerosis have more vulnerable for the management of this epidemic. So I think we should reduce the LDL cholesterol below 70 milligram per deciliter. Also, the more under the even 40 milligram for make the more further benefit of this epidemic management. The second point I wanted to stress is the diversity of intracranial atherosclerosis, intracranial arterial disease in Asian population. We usually think the intracranial arterial disease is caused by atherosclerosis, but we know that many other types of intracranial arterial disease can cause intracranial arterial stenosis. For example, if the patient
learn something new too, that
so for the residual stroke reduction.